And get started. So I'm going to begin with a prayer, and we'll go ahead and get started. This prayer is from our prayer book. It is on page 460. If you didn't know, there are prayers that you can use that can be useful in your prayer life throughout the prayer book. This is in a section called Ministration to the Sick, and it's a prayer for doctors and nurses. Our healthcare providers have been under such a strain through this whole now over a year. I find this prayer meaningful. Let us pray. Sanctify, O Lord, those whom you have called to the study and practice of the arts of healing and to the prevention of disease and pain. Strengthen them by your life-giving spirit, that by their ministries, the health of the community may be promoted and your creation glorified. Through Jesus Christ, our Lord. Amen. I'm going to turn it over to our new chair of the Formation Committee to introduce our guest today. Stacy Clayman has been the chair of the Formation, has accepted the call to be the chair of the Formation Committee, Adult Formation Committee, about a month ago. So she is now responsible for chairing the committee that invites speakers to this panel, as well as organizing our seasonal formation offerings. So if you have ideas about what you'd like to see in future forums, please do talk to Stacy about that or one of the other formation committee members. And with that, I will turn it over to Stacy for introductions.
Good morning. Thank you, Jeff. It is my pleasure to introduce Dr. Christian Reimers, who is the Chief of Population Health and Director of Graduate Medical Education at Family Health Centers of San Diego, a large federally qualified health center system serving nearly 200,000 medically underserved individuals throughout San Diego County. He completed his medical and public health training at UCLA, UCSD, Duke University, and the University of Washington. Dr. Reimers is board certified in internal medicine, infectious diseases, and in addiction medicine, and is particularly interested in HIV, hepatitis B and C, and service of medically underserved immigrant and refugee populations. He co-chairs the California chapter of the American Academy of HIV Medicine and has advocated for HIV, hepatitis C, and addiction policy at the state legislative level. He has served as a consultant for CDC-sponsored HIV, hepatitis B and C educational projects in Asia and Africa. Since 2018, Dr. Reimers has served as the Senior Clinical Advisor for the Clinton Health Access Initiative's Global Hepatitis Program, working to eliminate hepatitis B and C in 7 partner countries in Asia and Africa. Since the onset of the COVID-19 pandemic, Dr. Reimers has taken on a leadership role in policy, laboratory, public health, research, and clinical response. He is a core member of Family Health Center's COVID-19 response team, delivering bi-weekly updates to over 200 clinicians and staff. At the regional level, he serves on the County Clinical Vaccine Advisory Committee and Equity Task Forces. Dr. Reimers is a member of the National Infectious Diseases Society of America, CDC Clinical Call Escalation Volunteer Group. He has facilitated several telemedicine forums, including one on HIV care at the International AIDS Conference and a COVID-19 outpatient therapeutic series supported by Health and Human Services and Project ECHO. Internationally, Dr. Reimers facilitates a twice-weekly Spanish-language COVID-19 virtual community of practice for Latin America and has presented at an international World Health Organization Afro-region webinar on SARS-CoV-2 transmission. Please join me in welcoming Dr. Reimers to the forum.
Thank you so much, Stacy. I'm exhausted after hearing that introduction. It's been a very trying year for all of us, and I like to tell people I've sort of been preparing my entire life for this type of moment. So it's actually exhausting and exhilarating at the same time. But thank you for the generous introduction. I'm going to go ahead and share my screen. And I have some slides that I'd like to go through with you. And I thought what I would do, I thank Stacy for compiling all of your questions. I really want to spend a good amount of time towards the end of the hour going through all of your individual questions. But just to give a little bit of structure, we can start with some PowerPoints. As Stacy said, I've been doing these about every week or 2 weeks for the last year. So not really too hard to put together some slides, but let's go through just really a sampling of, smorgasbord here of general knowledge about COVID-19, starting with the epidemiology, which I think is always a good place to start. We'll talk a little bit about transmission and then pathophysiology. Treatment, we haven't had much to talk about until recently, but there are now some very good treatments. And then I know on the minds of everyone is vaccines, and so spend a nice bit of time on that. And then if we have time, we can talk about variants too. I was asked to put a slide up from the very beginning of the pandemic just to reflect, and it has been a time of reflection, I have to say, over the last couple of weeks since we're now hitting the 1-year anniversary of many events. This was from the first talk that I gave to our clinicians on March 11th, 2020, where there was 100,000 cases in the world and most of them in China. You can just barely see on the right-hand side, we were starting to have cases and deaths in the United States. I think 40 or 50 deaths had occurred at that point, mostly in Washington State and in New York City. The United States had 1,000 cases at that point. San Diego had just had our first. I think our first diagnosis was March 14th, if I remember, at Family Health Centers. And then here we are today, where we have 100 million cases, probably more than that. The United States leading the way with 30 million cases. This is just pulled from this morning from the Johns Hopkins website. And of course, we're leading the world in deaths as well, 550,000 deaths. It's just been a remarkable year, and I think as bad as anybody imagined it to be, and really kind of fascinating to see the social and political responses to this pandemic. I will say that, as Stacy mentioned, I do facilitate a forum, video forum for clinicians throughout Latin America in Spanish and actually some Portuguese as well. And Brazil is in absolute collapse right now. We just had a half-day forum yesterday, and the clinicians in Brazil the entire health system is collapsing. They have about 5,000 deaths a day now, which is worse than it's ever been anywhere in the world. Worse than New York City at the beginning of this. So we are doing a really good job in the US vaccinating our way out of this pandemic, but there are parts of the world that are still in crisis. Brazil, you can see, second in the world in deaths, and Mexico not far behind, with responses in both of those countries that have been very, very mediocre at best. In fact, the forum that we had was a little difficult to facilitate because many of the clinicians were very direct with their comments and questions on Zoom to the Ministry of Health and government officials that were presenting, actually. When you look at the global picture, we have seen actually in the last 4 weeks, this is from the WHO. And by the way, I feel like we should admit everybody from the waiting room as they're entering. Hopefully we can do that. We've had a real uptick in cases, and I think this is a reflection of a couple of things, probably society just opening up again, as well as the variants, which are becoming more transmissible. And after 6 straight weeks of decline over this winter surge, we've had 4 weeks of increase globally, really driven by places like Brazil and Europe. In the United States, this is my favorite website to go to. The New York Times has done a fantastic job of just very, very good data analytics and visualizations. What really worries people like Tony Fauci and Andy Slavitt and those at the White House Task Force is the fact that we are flattening out here, as society opens up at a relatively high number. You'll see that these number of cases on the bottom left in red are about where we were in the summer surge when we were very, very worried about this. So we're still seeing 50,000 cases a day. It's a little bit less than 1,000 deaths per day, and that's great. And the hospitalizations have definitely gone down. This is a complicated situation. Of course, every place is different. We're a very large and complex country. But we have vaccinated over 70%, I think, of the most vulnerable people above age 65. So what I think we're probably going to see is continued case counts, especially after spring break. Oh, there's Dr. Smoot coming in the waiting room. But we, to some extent, have protected our most vulnerable, and so we may see less hospitalizations and less deaths, and that's a really good thing. When you're a public health doctor or somebody like Tony Fauci, you don't want to see this high plateauing, because two major things that we've learned from this pandemic is that, what happens today reflects the policies of 2 weeks ago, and things can really sneak up on you. And then once we reach a point of exponential spread, where somebody's out in society and spreading, it's really hard to get back in control of things. So that's really everybody's concern. The one main theme that I will leave you with is that vaccination is absolutely the most powerful weapon that we have to prevent this, because if you have less and less carriers or hosts that the virus can infect, it tends to squelch things as they go down. California curves look a lot like the national curves. You can see that the cases have really gone down quite a bit after our winter surge. And then the deaths are on their way down, still a couple of hundred people dying in California per day. And again, there's a delayed effect. So the deaths that we're seeing are actually cases from probably a month or even a month and a half ago. So it's kind of like turning the Titanic. A very slow moving epidemiologic figure is the death rates. That's the longest delay. But suffice to say, on the bottom right, our hospitals are no longer overwhelmed. We do have space. In fact, there's some hospitals celebrating. Some of my colleagues on Twitter, which has served to be quite useful during the pandemic for really rapid information. Many places where they're cleaning their ICUs out, and finally we'll have a day of 0 COVID patients, which is really great to see. You and I have all been living the color-coded tiering system in California, and this is our latest map from the 23rd. This gets updated once a week, and more counties are moving into the red zone, several into the orange, and some even into the yellow, which is really a cautious way to reopen society and all the policies that entails. This is really quite a sophisticated calculation, and it's been altered a couple of times during the last 6 months or so. But it really takes into account several, data grounded figures, and that's the test positivity rate, the number of tests that are being done in a county, the positive cases per 1,000 individuals, and then also some additional metrics such as health equity metrics to really see if counties are doing a good job reaching the most vulnerable populations. And as you can see, San Diego is in the red zone here. And probably headed towards orange as long as we can sort of hold the course and continue vaccinating. And then finally, zooming into San Diego as our most granular view of this, I want you to focus in on these orange bars here, which is really the number of new cases reported per day. In the old days, we used to really target a number of about 200 cases in the county per day as a good indication that we were headed in the right direction and going to be able to move down the tiers. Expectations have really changed because we had days with thousands of cases, up to 2,000 to 3,000 cases in the winter surge. And so these all look relatively good, but keep in mind, this is about the level of transmission that we saw during the summer surge. Very different place right now, obviously, with vaccinations ramping up, but still a little concerning to me, particularly when you drive around Bankers Hill and North Park and downtown and you see people really out and about. It's not a time to let our guard down, but suffice to say 200 to 400 cases per day that we're still seeing in the county. And the turquoise bars, by the way, are the number of tests that are being done. And I think, we want to reach around 10,000 tests per day for our population. That's about what we should be striving for. So I'll move into just some of the pathophysiology and transmission related topics here. There was a question that came in the registry about are masks really effective against COVID, and what are the best masks to wear? By the way, I took the Q&A that was compiled by Stacy and sort of, as much as I could, answer those questions and put my favorite links in there, and I can get that back to the congregation for further reference. But this is just a graphic from Science magazine. The science is overwhelmingly in favor of masks being able to block viral transmission, particularly in the situation where you have universal masking. And that's because of this idea of asymptomatic transmission. Some people get COVID or get SARS-CoV-2 infection and really don't know it. And that's been a hard lesson to learn. It took a while for people to come around to the idea that you could actually have asymptomatic transmission, but it looks like 40% or so of cases, if you were to look at a whole summation of cases, 40% or so are asymptomatic. And so you really don't know who around you could give you the infection. And this continues to be one of the most vexing parts of this, is that even if you feel fine, you could unknowingly pass this disease to somebody who is much more vulnerable than yourself. And as we move into vaccination and how to think about risk in terms of interacting with family members, that's the one thing that really still concerns us, is that even if you are fine and you're a very low risk individual, let's say you're a college student or a grandchild and going back to high school, what could still happen is an asymptomatic infection transmission to somebody who is very, very high risk. So universal masking dramatically reduces the ability to transmit. The one flaw with this figure, which was found out a little bit later, is that there is probably some transmission through the eyes as well. And so in addition to masking, wearing eye protection is something that we do in the clinical setting, and that probably would be the best way to protect yourself. There's plenty of data. I'm not going to go through all of it, but in any situation where universal masking has been introduced, the case rates fall. And there's no other explanation than universal masking just being extremely effective at preventing transmission. So hopefully that answers that question. I think we often lose sight of the timing of how this disease actually manifests, and actually how slow it can be and how sneaky it is. We are so used to a 24-hour news cycle where we want to know things day by day, and it just doesn't work that way. Those daily case counts that I showed you, even from San Diego, those 400 cases from yesterday, may have been transmissions that happened in the last 2 weeks, and they may manifest in hospitalizations and deaths over the next 4 to 6 weeks. So just to go through the numbers here, the incubation period is on average about 5 days. And that means that after you're exposed to somebody or some environment where there may be transmission, it can be up to 14 days before you actually get sick and start to have symptoms. On average, that's about 5 days. Typically, people don't immediately seek care after they develop symptoms here. And so there's sort of another 3 to 4 day delay. They may come and seek a diagnosis at that point. And then really that first week is often people just have some flu-like symptoms, maybe some muscle aches. But when people really do get sick and go into the hospital is not even until 7 to 10 days after that. And it goes to show that there's sort of different phases of this illness. That's when people get really sick and need to go into the hospital. And then I put 10 to 14 days between admission and death. It's highly variable from person to person. Some people end up being in the ICU and on the ventilator for weeks to months. And so some of the deaths are really, really late. And I showed you just a picture here of, if you were to do a CT scan of somebody's lungs, this is sort of a cross-sectional view of the lung fields in black here. At the very beginning, there are some very subtle signs of disease in there in the lungs. And really what happens is that this moves into an inflammatory phase where the body's own immune response is actually overwhelmingly destructive at that point, and leads to the lungs filling with fluid and death. And really there's not much to do at that point. Even a high level of aggressive medical care with mechanical ventilation, if the lungs are that damaged, there's not much to be done. So we've thought of this as really a two-phased illness, where there's a viral phase in the very beginning, and then at some point there's a turning point, usually 7 to 10 days after symptoms develop, where we move into an inflammatory phase. And we sort of devised our treatments based on these two different phases of illness. We now have many things we can offer, actually, as you can see on the bottom. The rows here just sort of talk about the severity. The middle part is the pathogenesis, where viral replication is really the main player in the beginning. And then we move into inflammation, which is more of an immune system problem. And then hypercoagulability, where we've seen a whole lot of problems from blood clots, especially in the lungs. And so our treatments really are designed for those three different phases. And we now have a lot of antivirals that are being investigated. Unfortunately, many of them that looked like early easy wins, like hydroxychloroquine and azithromycin, have turned out not to be effective at all, now that they've been very well studied. But I have sort of highlighted here antibody therapies, and I just want to highlight that a little bit more. We've been offering this since December at Family Health Centers, and these are incredibly effective therapies for those that have early and mild disease and are not in the hospital yet. So very rarely in medicine do we have something that's this effective. It's sort of 70 to 80% effective if you are to get an antibody treatment early on in the phase of disease. And so there's actually some effort to expand these therapies and get to people before they get too sick to be in the hospital. Once you're in the hospital, most of the treatments are actually more designed to reduce inflammation. So that's things like corticosteroids or immunomodulatory drugs. But it's almost like it's too late at that point in terms of addressing the actual virus itself. And then there's a lot of interventions on anticoagulation to prevent those potentially deadly clots. But that's not the whole picture. There was a question that came in the registry about, if I'm relatively young and healthy, do I really need to be worried about COVID? And the answer is absolutely yes, you do. Because there's this entity that has been very mysterious. We're starting to characterize it a little bit better now, but it's called long COVID. Dr. Fauci and the NIH just renamed it and gave it a little bit more of a technical name, which is post-acute sequelae of SARS-CoV-2 infection, or PASC. And it looks like from the studies so far that about somewhere between 10 and 30% of people, no matter who you are, and no matter whether you even have severe symptoms or mild symptoms at the beginning, 10 to 30% will go on to develop symptoms beyond a month after their infection. Huge range of manifestations of this, from fatigue. I think fatigue is probably the largest bubble here, if you can see that. Fatigue, shortness of breath, a very consistent description of brain fog or trouble thinking, sleeping disorders, fevers, and what I would call autonomic instability, where the heart rate and the blood pressure just have wild swings, gastrointestinal symptoms, anxiety, and depression. And it's just been a big head scratcher for us because we don't have much to offer at all. It originally was thought that this was going to be more common in people with severe illness who had been in the ICU. The original reports out of Italy and New York about 30 to 40% of people that had those long and severe bouts with COVID having these symptoms. But this is not really thought to be true anymore. It's anybody, including young and healthy people. And there are more and more tragic anecdotes about high school athletes who are unable to return to the field because they just have persistent symptoms, and essentially their athletic careers are over. So it's not a common thing. It's not like everybody's going to have this, and certainly plenty of people can have a mild case and really get over it and not have a trouble from COVID-19, but some people do, and we don't know how to predict that. Here's just a study from the University of Washington looking at a large mix of people, the majority of them that were never in the hospital, 85% as outpatients, and 31% of them eventually developed long-term symptoms. We're just now starting to peel the onion on this and understand it a little bit better, but it's a really concerning thing to take a previously healthy young person and have no answers for them, and now they develop basically a chronic fatigue syndrome after this infection. In one of our forums that we have for Latin America, I invited the director and the founder of this support group called Survivor Corps. Her name's Diana Berendt from New York City. She actually had long COVID. She had an asymptomatic COVID infection and then developed essentially chronic fatigue type symptoms. Very robust organization. They're doing really, really good work to promote research and all that kind of stuff. And greater than 150,000 members, which is really quite shocking, and just gives you an idea of the scope of how common this is. Okay, so I'm moving to vaccines, and then I'll stop and sort of run through the questions. This is the overall picture of the originally supported Operation Warp Speed vaccine candidates. So Pfizer, Moderna, Janssen or Johnson & Johnson, and then Oxford, AstraZeneca, Novavax, and Sanofi Pasteur. And Pfizer and Moderna were really the first out of the gate, which was a new technology, the mRNA technology. I just put a bunch of statistics there, 94 to 95% overall vaccine efficacy. I've given a lot of talks to skeptical communities of color because they say this is the same old thing as the Tuskegee experiments. And I like to highlight that there were two prominent Black scientists, both involved in development of both of these vaccines. Kizzmekia Corbett is the leader of the NIH team that eventually developed the Moderna vaccine. And you should follow her on Twitter. She's quite a spark plug there. Just a real role model for young Black women. We now have Janssen or Johnson & Johnson that's approved as well. So I'll focus my discussion on those three. And then I know there were some questions about the Oxford AstraZeneca vaccine. Not probably that relevant for our vaccine program in the United States, but actually very relevant for the world, since this is a vaccine that's about 1/10 of the price of the other ones. So I'll get to that a little bit. And then probably in the next week, we're gonna have Novavax present their data to the FDA, or at least release their data from their trials. And then the last one, Sanofi Pasteur, had some major delays and is way behind everybody else, so may not even end up being a big player. The overall picture is that all these vaccines, including some that are not approved in the US, I put Sputnik from Russia and Sinovac from China as well, variable degrees of effectiveness against all disease, but highly, highly effective at preventing hospitalization, as I've highlighted in the yellow column there. These vaccines are saving lives, and they're being used all over the world. very, very few safety signals from any of these things. So it's just remarkable how effective all of these are. Let me get into a little bit more detail about each one of them just very quickly. The Pfizer was the first out of the gate. This is a collaboration with BioNTech, which is a German company. And just so you know how to read these curves, the blue line here is the number of cases developing in people that didn't get the vaccine, who got placebo. The red line is those developing cases who got the vaccine. And what you see is this dramatic separation of those two curves at about 14 days following the initial dose, actually. And the way you calculate vaccine efficacy is by stopping the clock at the end of this and sort of seeing how many cases occurred in the placebo arm versus the vaccine arm. And this is a table from the original paper in the New England Journal. You can see that 162 cases in those who got placebo versus 8 cases in those that got the vaccine. That's what gives you the 95% efficacy, which I think is just well beyond anybody's expectations. The FDA was originally prepared to approve a vaccine as long as it had 50% efficacy, and this just blew this well out of the water. The technology is new, though, so this deserves some explaining. It's not, I should say it's not too new. There's people that have been working on this for 10 years, really, to get this to this point. But it is an absolutely ingenious way to think about developing a vaccine. So you don't have any live virus at all. You have just the genetic material, just the mRNA, which is a very fragile and short-lived molecule. The mRNA needs to be protected within this lipid nanoparticle, as you can see, which is just a tiny little, we call it a tiny little droplet of butter, to really save that mRNA and allow it to enter into the cells, the muscle cells, as well as the immune cells. It does not enter the nucleus or the DNA of the host, and just does exactly what a vaccine needs to do, which is just show the immune system the protein of interest, and that's this red spike protein here. Lots of science that led up to this, and it's a platform that I think will be used in more and more vaccines because it is incredibly efficient. From the time that the genetic sequence of SARS-CoV-2 was published by Chinese scientists, it was 60 days until they actually had the first prototype vaccine into somebody's arm. So the speed with which we could develop vaccines in the future for any future outbreaks is just absolutely magnified by this technology. Now, just a cautionary tale. This was a case in San Diego that actually hit the airwaves around the world. I got asked to comment on it by 10 News here. And I had colleagues from India and South Africa texting me and tweeting me saying, I just heard you on our morning news in South Africa. So this got picked up by Reuters and the international news, that shocking truth that you can actually get COVID after getting the vaccine. And that's because the vaccine doesn't start working immediately. I showed you those curves do not separate until 14 days. And then even at that point, they don't separate completely until probably 14 days after the second dose. And this poor nurse went back to work after getting his first Pfizer vaccine and actually got sick within a week. So the vaccine didn't really even have a chance to work. So not too shocking when you understand how the vaccines work, but it did kind of make the news. And I did a little personal experiment. I know Dr. Smoot loves me to show this, but these are rapid antibody cassettes that we never ended up using at family health centers, but we were thinking about it, and these were about to expire, so I kind of just used them on myself. But this is just mapping my own immunological journey to show you what happens here. The C band here is the control. That should be positive to tell you the test is actually working. And then the G is the IgG, or the real antibody that you want. So I did a test on myself in October before we had vaccine approved. I got my first Moderna vaccine in December 28th. On my wife's birthday. And then 10 days after and 14 days after I did another test, you can see that G line is still negative at 10 days, so not protected at all. And then you start to see a little bit of a faint band here at 14 days. Got my second dose in January, and then actually, I think about 2 weeks after that, a very strong and robust response from my own IgG. So it's really nice to see that. It feels amazing, as those of you that have been vaccinated, I think you can probably tell, just to feel that protection around you. Quickly on Moderna, very similar looking curve here, where you have 94.1% protection when you do all the math and add up vaccine efficacy. Again, a separation of the curves at around 14 to 21 days. There are some very slight, subtle differences between Moderna and Pfizer in terms of administration, but largely they are the same platform and very, very similar efficacy. We saw the first bit of data from this Moderna trial that you could actually prevent asymptomatic infection and therefore prevent transmission. But this was done in a very limited way in this particular trial. They just did a nasal swab of everybody before they got their second dose. And using that, we're able to calculate that 14 people in the vaccine arm had an asymptomatic infection and 38 people in the placebo arm. So about a 50 to 60% efficacy, at least at that point, at preventing transmission and preventing asymptomatic infection. We have much better data on this from the Johnson & Johnson trial that I'll review in just a second. But at least the first hint that vaccines not only prevent disease, but also asymptomatic transmission. And so finally, with the J&J data, another curve that you'll see here, it looks a little bit different. It's a single dose vaccine, but still really good separation and not such a complete shutting down of transmission. There's a couple of reasons for that. The first being that this was tested at a different time in history when we actually had variants circulating around that are more contagious in South Africa and the UK and in Brazil. So that's why you end up with a slightly lower overall efficacy number, but I'll show you that I think is not what we should be focusing on. Overall number of protection here on the far right-hand column is the vaccine efficacy, that's about 66%. But when we look at different outcomes such as severe disease or critical disease, it actually looks better than that. I should mention just out of context that this was tested as a 2-dose vaccine as well. And there's an ongoing trial of people getting double dose, and we'll see that published probably soon. Excuse me, but the company made a decision just to go with it and present their data to the FDA as a single dose because I think they were confident that it was good enough to get the emergency use authorization, and it was in fact. But highly different effectiveness in different regions. So in North America, the efficacy of the Johnson & Johnson is 72%. In South Africa, it was 64%. And in Latin America, which was mainly Brazil, it was 61%. And I think we can explain these just by the difference in variants and the interaction of vaccine protection versus the circulating variants that are going on there. But just to reassure everybody, when you look at different outcomes that are probably more clinically important, such as severe or critical COVID on the top left here, COVID requiring medical interventions such as oxygen on the top right, and then COVID requiring hospitalization on the bottom right, the efficacy is more like 85 to 100% in terms of protecting from severe disease. So really what makes up that margin between the Pfizer Moderna 95% versus the J&J 66% are really mild or asymptomatic infections. So not all that clinically relevant. And it leads to the idea that you've heard over and over and over again from officials, which is get the vaccine that you can get. They're all really, really good and powerful in protecting you. Bottom right, I just put one last thing in there about protection against asymptomatic COVID. In this particular trial, they looked in a much more active way to see what type of protection was being offered. And that's that number 74% down there on the bottom in terms of protecting you from asymptomatic COVID. So that's not perfect, but it does show us that being vaccinated is doing a pretty good job at preventing ongoing transmission. I think I'm going to skip for the sake of time and just get to the variants, because I think that many of you wanted to know about variants. Oh, sorry, I should talk about safety too. A little bit of concern for AstraZeneca because of blood clots that have shown up. I don't think this story is finished yet, because these were not just sort of garden variety blood clots. They were a very particular type of blood clot in the brain, not necessarily in the lungs or in the legs. And so especially in Germany and Norway, they kind of raised the red flag that this might be something to pay attention to. The European Medicines Association, which is the equivalent of the FDA, looked very carefully at this and made a distinction that the benefits outweigh the risks by far. It doesn't mean that there's nothing going on here, but it means that it's at such a low level that we really should proceed with vaccination. The one thing that bothers me a little bit about this is that the type of clot that's happening looks like it may be a specific immunologically related clot. And even though that's incredibly rare, it does make me a little bit concerned still. But you have to balance this against a situation where you have thousands of people dying every day of COVID in Europe because of their sluggish vaccine response. And the lives that can be saved by widely implementing this vaccine far outweigh the risks of maybe 1 per 500,000 or 1 per million that would develop a clot like this. Quickly, anaphylaxis was a major thing in the Pfizer and Moderna early on, and I just want to say the numbers here are just so small that this really is not a major risk unless you've had a history of having anaphylaxis in the past or you have a heavily allergic history. This is from the original reports showing that most of these reactions occur within 30 minutes, which is why those with severe allergies are asked to wait 30 minutes after their vaccine. Here's for Moderna as well, but the risk being 0.001% for the general public. So very, very, very small. That's far less than the risk of getting struck by lightning, I think. So not to be too worried about this. And here is an allergist, a group of allergists in San Diego formed a coalition to try to dispel some of the myths out there. She has a severe peanut allergy, actually, and went to get her vaccine. She falls in the yellow of medium risk here, waited just an extra 15 minutes, had her EpiPen with her, and did just fine. So very few people that are high enough risk that would be contraindicated to get the vaccine. And just to give you the numbers here, when they looked at the Moderna and the Pfizer, the anaphylaxis risk down at the very bottom of this column is about 2 to 4 per million. So really, really kind of a low risk. There are a lot of questions about safety, and I just want to say the United States and the CDC has the most robust safety programs in the world. It's the gold standard of how to evaluate a drug or a vaccine after it's been approved. This is an old figure I took from the end of February, where 55 million people had already received the vaccine. We have almost 4 million people that have completed an active surveillance through this app called vSafe. And then 30,000 pregnancies have already occurred. And I just want to reassure you that the safety has been so thoroughly looked at, not through just vSafe, but this other one called VAERS, which is a passive reporting system. And we're just not seeing anything new or different from the clinical trials. So yes, there is sort of this 1 to 2 day mild adverse effect profile that it looks about the same between Pfizer and Moderna. Not enough data from Johnson & Johnson to really address this yet. But they're looking for more rare events as well. And there's nothing that's showing up. And they're doing this in a very, very rigorous way with comparator groups. You can't just say, well, there's been 4 cases of Bell's palsy, and so therefore there's a association. You have to compare it to an unvaccinated population. And whether they're looking at Bell's palsy, which is a facial paralysis, clots, Guillain-Barré syndrome, problems with clotting or platelet levels, nothing is showing up. And this is being done in a very, very rigorous way. And so it really reassures us that we're looking at 5 million people that have filled out these kind of things for safety, and just nothing's really showing up with the vaccines that are approved in the US. So I think I'm going to stop there and try to get to your questions, and I'll bring them up. I also, any of you that want to put some in the chat, maybe I'll go to that first, and we can spend really the rest of the hour, if that's okay, talking about, okay, so I'll start with the ones that are in the chat, and then I have a nice point that's been compiled by about many of your other questions. So for those that are going to travel by air, is eye protection important with goggles? So I would say yes. I actually had to travel right in the middle of the summer surge because my mother passed away, unfortunately, and had to take a flight up to Northern California. And I would say the best that you can get your hands on an N95 or a KN90. I would try to do that. I would not eat or drink on the flight if you have any choice. And I would do just some eye protection with goggles or a face shield as well. The airflow in an airplane, I'm told by the environmental engineers, is actually quite good in terms of minimizing the respiratory virus. The way they design airplanes is just to have the air flow down. And that's apparently a really good way to keep sterile air from circulating. So it's actually working in your favor. There have been a couple of outbreaks associated with long plane flights. So it's not like it's completely foolproof. And that's why I would take the extra measure on your own. Gas mask that you possibly can. If you can't get an N95 and 90, the CDC now has advised wearing 2 masks. And the way to do that is to use a disposable mask under a cloth mask, and just make sure it fits well and you don't have big gaps in the side of your face. And then I wear goggles still at work, or just really nice, lightweight, clear, actually sort of construction glasses made by Milwaukee are my favorite brands, actually. I would do that if I was on a flight as well. And then obviously the longer flight, the higher risk. So you're just, it's people going transatlantic or trans-Pacific flights, that's a higher risk situation. I would bring alcohol and sort of sterilize everything around you. And again, try not to eat. It's a very simple concept that places where you eat or sing or talk loudly are higher risk, because you generally have to take your mask off to eat or drink. And then places like gyms and places where you're singing a lot are much more likely to expel particles that way. And I'll just follow that by saying, I know there was a lot of questions about when can we reopen our services. That's a little beyond my pay grade, and I have some links to the state criteria, which I think are going to be what we're going to need to follow because of the legal and judicial ramifications of opening and closing, that type of thing. But early on in the pandemic in Washington state, there was an outbreak of, I think, 40 or 50 cases in a choir practice where it was sort of before masks were widely used. And so singing is a very efficient way to transmit the virus. And I think there was even a couple of deaths from that situation. So people are a little gun shy about that situation. Let me get on to the second question. Boosters, will boosters be needed? I think it really depends on how quickly these variants take root. We have seen there's really 3 variants, so actually 4 different variants that are concerned. And these are just mutated strains of the virus that have developed a slightly different genetic profile in terms of mostly in the spike protein. That's the first interaction that virus has with our bodies. And it's made the vaccines just a slight bit less effective. Some of them still do a pretty darn good job. I have to say the Johnson & Johnson vaccine still looks like it's pretty robust against the variant from South Africa and from Brazil. But the companies have already started testing whether we're going to need this and whether they can use them or not. I can't predict whether we're going to need them, but they will be ready, I would say, within a couple of months. And as I mentioned, this mRNA vaccine platform allows us to really rapidly pivot and develop new boosters. Pfizer has taken kind of a different stance where they're just giving their same vaccine a 3rd dose instead of 2 doses. They're giving 3 to see if that protects well enough. And I think time will tell. We'll just wait and look at the data and see what happens there. I can't really predict whether this is going to be a seasonal virus or not. The original SARS-CoV-1 just basically disappeared and became extinct. So that's a possibility. The second major coronavirus, which is called MERS, still is having little outbreaks here and there, just kind of unpredictable. I think the fact that we put literally billions of dollars towards developing highly effective vaccines might work in our favor over the long term, because it looks like vaccine-induced immunity is probably better than natural immunity you get from the infection. So as Yogi Berra said, predictions are really tough, especially when they're about the future. So I don't I don't like to weigh in too much on that. Vaccine efficacy against post-acute syndrome. So this is a really interesting question. The long COVID syndrome that I mentioned, or PASC, what does vaccine look like for that? Nothing has really been published to this effect, so I can't answer that for sure. But I'll tell you that group of the support group called the Survivor Corps. I actually, at the very end of our forum that we had the president and founder, I asked a hesitant question and said, how does your community of long COVID survivors feel about vaccines? And I was a little worried they were going to say we're anti-vax and we don't want to touch it. They are seeing very strong anecdotal evidence that getting a vaccine, if you have long COVID, improves your symptoms, which is very hard to understand physiologically, but it's interesting, and we'll wait and see if that's the case. So it's kind of good news that at least that community is very much pro-vaccine because of the anecdotal evidence that they've seen. I think the question is also about, can the vaccine, I guess that's the question, is does it help people with long COVID? And the answer so far looks like it probably does in some cases. Not a lot of scientific studies that have been published about that. Okay, if you previously had COVID, would you be less likely to have side effects from the vaccine? So good question, and the answer is actually, on the contrary, you are going to have more side effects from the vaccine if you had previous COVID. So we know from a couple of published papers now that significantly higher side effects, like on the 20 to 30% higher range, depending on the side effect, if you've recently had COVID. Now, at Family Health Centers, I've looked a lot at this, and our general policy is that if you've just had COVID, you don't need a vaccine right now. There's a couple of schools on this. Some people say, well, every missed opportunity to vaccinate is a really important missed opportunity. We don't want to let people, have their time in line. But when you look at rates of infection, when somebody has had COVID, it almost never happens in the next 3 months. So what you're doing is a vaccine that protect somebody that's highly vulnerable, and you're giving it to someone who already has their own immunity. And in my opinion, that's a vaccine that should be given to someone else who hasn't been vaccinated or exposed to COVID yet. And in addition to that, clearly people have higher levels of side effects when you give the vaccine, because it's really the second time that they're seeing spike protein and developing that immune response. So I had some figures I could show you, but suffice to say that really in all the vaccines that have been tested, if you have had it and then you get the vaccine immediately after, you are going to have more side effects. So our policy is to wait 90 days and then get the vaccine. Next question, why haven't they been able to develop a vaccine for the common flu with the same efficacy as these COVID vaccines? So it's a question of mutation, and the genome of influenza is actually such it can shuffle around and mutate much faster than coronavirus genomes. And that's why every single year they have to redevelop a brand new flu vaccine based on just a guess or a prediction of what flu strains are circulating in the Southern Hemisphere. So just to go a little more in depth, the flu genome is a set genome where you have 7 bases shuffle around in places like in Southeast Asia where you have human and pig and avian ducks and chickens, kind of very, very close proximity. And the influenza virus is great at sort of shuffling around between those 3 species and mixing around every year. So it's very, very unpredictable. There's a lot of work going into trying to develop what's called a universal flu vaccine and to try to get around that. And guess what? It might use this mRNA technology to try to do it. So we actually might be able to do it coming soon, but a lot of it has to do with how fast things mutate. And coronavirus, even though we're talking a whole lot about these variants, doesn't tend to mutate as fast as many other viruses. So that kind of helps explain that. So great, let me share my screen again, and I'm going to get back to the longer list of questions if I can, to make sure we have answered all these other things. Okay, so comparing 1 year ago to the current information. So I'm going to give you all of these different links and I'll send this back to you. I just want to take you on a little tour of the county website, which has a lot of really good information. This is coronavirus-sd.com. And pretty much everything that you're going to want to see is going to be in here. For example, to your question about reopening, if you just go up here, there's a link to reopening, and you can scroll right down to places of worship, and this is going to be the best information that you can get here. So in terms of how to do things by tier, like I said, the state guidelines here are likely to supersede any other local guidelines because of the sensitivity of reopening and the legal ramifications of that. So I would say this is your best source there. Going back to the original website here. So this actually, let me go back a couple of more so you see where that launching page is here. So this is the coronavirus-sd.com. I typically go to this coronavirus in San Diego site right here if you really want to look at all the data. And this is where all the dashboards sit here. So there's a COVID dashboard of cases. There's a geographic case rate locations. There's triggers that the county is looking at. And there's the vaccination dashboard. And then all the other statistics are here. So a lot of what I pulled to put in the PowerPoint are all here if you feel like tracking the data. This one right on the top here is my favorite one to look at on a daily basis, because this is sort of the local curve of what's happening there. So that is a very, very valuable place to look. Let me get back to there, and I'll put all of these other links with you. There's one to the WHO site and the New York Times site as well. You got answered the one about masks. What are the best masks to wear? So I should say that, there was a time in the very beginning that we were very nervous about the public taking all these supply of masks that we needed our healthcare workers to use. And that's why it actually took people a while to come around to universal masking. And you may remember the famous tweet from the Surgeon General at the time saying, please stop buying masks. And that was used against him later. But now the supplies are better. And I would say what's called a surgical mask or a medical mask that's made from this sort of blown synthetic fabric rather than a cloth mask is a little bit more effective. And that's because it has some ionic charge to it that actually stops the viruses from coming in. So that's probably the best if you can get a big pack of those. Those are generally felt to be best used as a disposable type of thing because they stop working when they get soiled or when they get wet. The CDC now has recommended if you're going to use 2 masks that you use a surgical type mask on the bottom and then a cloth mask on the top. And then sort of one level up from that would be what's called a KN90, KN95, or an N95. And those are just much more tight fitting. They really don't allow a lot of particles to get in. But the point of the CDC developing these criteria for masks, and I'll show you just sort of the link here that actually I put on your thing, is that when you take a surgical mask like this and you put a cloth mask over it, you basically get, by combining the two, essentially the same efficacy as an N95. And so that's kind of why they said you can sort of do your own type thing here to give you that degree of protection. There's also advice here on doing what's called a tuck, a knot and tuck to get rid of those air spaces on the side if it doesn't fit your face very well. Okay. We're getting close to the end of time, but let me make sure that I get to some of these other questions. Can we believe the vaccines are safe? I think I went over that. I put the link here to the data from the CDC. What variants are we concerned about? Okay, let me get to this really quickly, and I'll show you one slide in particular that I think kind of sums it up, especially related to the Brazil variant, which has been discovered in San Diego. The variants, it's a fascinating story here if you're really into the science, you know, the evolution that's happening right in front of our eyes, from the ancestral strain here from Wuhan to all of these different mutants essentially. And we have displayed on this slide just the different ones: the UK variant, the Brazil variant, the California, there's now a New York variant, and the South Africa one. And just these have basically traveled throughout the world. And it just shows us that global and international travel is really not a great thing in terms of disease transmission. So these are all related to each other, and they just sort of show up in different places. That's kind of nice just to see the sort of family tree of COVID. And the Brazilian variant here is this one called P1. And it looks like the most concerning thing to me is that it has a reduced ability of our immune responses against it to stop it. So it looks like convalescent plasma, which means people that have already been infected with COVID-19 have reduced neutralization. Also post-vaccination sera, people that have been vaccinated, it looks like they work a little bit less well on that P1 variant. And then what's most concerning to me as a treater is that the approved monoclonal antibodies don't really work as well against this variant. And let me just show you one slide in particular that really sums up all of those points in a single piece of data, is actually down here. So this is one slide showing the P1 or Brazil variant and how convalescent plasma behaves compared to the wild type or the Wuhan. And you can see that these black dots here fall pretty significantly over to that Brazil variant in terms of the efficacy of convalescent plasma. So that's people that have been infected already. Over on the right-hand side, you have Moderna and Pfizer. You have a small but significant decline in the effectiveness of the immune response. This is all in vitro, so this is just experimental data here. And then what's most concerning to me on the top here is the antibodies that we're currently using at Family Health Centers are the Eli Lilly combination, this green and purple, and you see the efficacy completely goes away, which is pretty concerning compared to wild type on that Brazil variant. And I'll go back up if you just bear with me one second. There is a cautionary tale with the Brazil variant, which it has to do with this place called Manaus, which is the largest city in the Amazon. And what happened there is that they had a very large wave of infection in the summer, in May and June, where they had all of these hospitalizations and deaths here in the blue and the red lines there. And somebody did a study in the city of Manaus to estimate how many people actually had been exposed. And they estimated that 76% of the population of the city had been exposed in this really aggressive first wave. So you say, well, 76%, that's pretty good. That should give you herd immunity, essentially. Well, fast forward 6 months, and actually when the variant started coming here, this is the P1 variant that now came in, almost the entire population was reinfected. And you had actually higher levels of hospitalizations, higher levels of death in Manaus, indicating that prior infection with the original strain was not protecting these people at all from this P1 strain. So this really is a cautionary tale that the variants can overcome our immune response. So let me stop sharing there. Hope that was clear. And I think a lot of the other questions I sort of addressed. Is it safe to travel if you've had 2 doses? I think there are safer ways to travel. We can't, we can't get into the COVID risk absolutism, because there will never be something that's 100% safe. And we have to make complicated decisions about how we want to proceed with reopening our society with different levels of risk. It is definitely safer to travel after you've had 14 days past your last dose, whether that's a single Johnson & Johnson or 2 of the Moderna or Pfizer. So I wouldn't recommend traveling until you are fully vaccinated. And then, as I mentioned, getting the best mask you can, not eating or drinking on the flight, keeping your hands with alcohol, and then probably wiping down your seat. And then trying to distance between people. I know some airlines have done a better job than others in terms of allowing the middle seat to stay open, but of course that's an economic decision for them. In terms of traveling abroad, I wouldn't really think that's a very good idea right now. And that's because, like I said, some places in the world are in the worst possible situation throughout the entire pandemic, namely in Europe and in South America and in Brazil. Lots of other questions about cathedrals and risks of in-person gatherings. I think I mentioned that, it's not 100%. The vaccines are not 100% for asymptomatic transmission. And so if somebody does get a mild case, they could always pass on to somebody who is not fully vaccinated. And that still is a risk. And as I mentioned, being indoors and singing is a way to sort of pass on the virus. If everybody in the entire place has a mask, that's safer. And then if everybody in the entire place is vaccinated, that is way safer. And that's, I think, kind of where we're headed in terms of allowing larger group events such as amusement parks and sports events and that type of thing to continue to happen. So then I'll finish with a school reopening question, which has probably been the most controversial area. This is a comment: my younger grandchildren do not want to go back into in-person learning, but they are in need of socialization. They need to be with peers in person. How long do you think it will take to get the students socially up to their age level after 1 year plus of being confined to home? So very difficult question. I think there has been a realization that schools are very important places, that social interaction is very important, especially for younger children, that there's also some harms at home in a lot of places where there's maybe some child abuse or some food insecurity. And so the benefits of going back to school have to be really weighed against the risks. Somebody asked about when children are going to be able to be vaccinated. So I'm happy to say my 16-year-old son got his first vaccine yesterday. And then my 12-year-old is just dying to participate in a clinical trial. But I think within about a month or two, probably we'll have completed the trials in adolescents age 12 to 16 or 12 to 18. And Moderna and Pfizer will probably be approved down to those ages. It looks like much younger children below that have lower rates of transmission. And that's actually why the CDC has revised their guidelines and said that just 3 feet of distance is probably okay, as long as there are universal masking protocols in place. That's actually based on really scientific studies, not just sort of arbitrarily choosing 3 instead of 6. But in terms of the socialization, this is going to be a challenge for our society forever. I think we're going to have to really put some work into getting kids back up to speed. And then a final comment: my high school grandson does not want to go back to class in person. He doesn't trust the other students or the school to adhere to CDC rules for returning to in-person learning. You do not know the students or what the school will do at the time of opening, so this may be unfair. His concern is that masks will not be worn all the time, and there will be congregating of students in an unsafe way. None of them will be vaccinated at the time they're scheduled to open. Do I think his concerns are valid? So I do think his concerns are valid. I have this conversation with my kids every day. But I think my kids have a pretty sophisticated understanding of COVID because of all, it's COVID every day, all day around our household. But you really do have to be suspicious of everybody not, I don't know where you were last night and how many people you were around. And so schools that are able to enforce masking, I think, is probably the one most effective intervention. My son goes to St. Augustine, and they've actually been open in person most of the time throughout the pandemic. They're a private school, so they're allowed to do that. They've had cases reported, relatively few, 1 every week or so, and they have enforced masking with disciplinary action. So you get a detention if you don't have a mask on. And they've been able to do that and keep the cases relatively low. So It's really a complicated question. The benefits of getting back into school, getting in-person interaction are great. And now that we have our most vulnerable people, including, all the teachers should be vaccinated. All those over age 65 should be vaccinated. It's a tough decision. The fact that we're seeing some long COVID in young athletes is the one part that makes me still a little apprehensive that this might be a little too early, but boy, it's tough to make that call. I think we're headed in the direction where we're going to be cautiously reopening in-person learning going forward. So I think I'm out of time here, so I'm going to stop and turn it back over to Stacy.
Oh, actually, we have just a couple more minutes. I had 2 questions come in, if that's okay. I'm fully vaccinated. I'm indoors for some period of time with someone who's previously contracted COVID and is now recovered but not vaccinated. Am I at greater risk?
So I mentioned this a little bit, that I think protection from the vaccine is better than protection from the natural infection. So I mentioned the vaccine gives you sort of 75% reduction in asymptomatic and up to 95% reduction in infection. That person who's not been vaccinated probably is at greater risk than you are. And so I would encourage them to get a shot. Again, they can wait 90 days if they like. But that's a pretty safe situation when you have immunity in both people in the room. Not too risky there.
And then just one other question. I've heard it's okay to hug my grandchildren. They've been indoors, unmasked at their friends' homes, and the parents are probably unmasked. Is it still considered safe for me to hug them?
Yeah, the CDC has developed some really good resources on this, and I wish I had time to get it's if you just sort of Google what to do after vaccination and what your risk is after vaccination, they have nice little graphics, and they're actually, they gear up these different scenarios where you have a grandparent who's vaccinated and a young person not at risk who's not vaccinated, and those are generally considered safe within the household. Now, the CDC is not going to say go out to big settings and restaurants and that type of stuff with many, many people, but in a single family, it is generally felt to be safe for you to hug your grandchildren if they are considered to be low risk, because you have a very, very low risk of getting them sick and they have a very low risk of getting you sick. So the answer to that is yes, thank goodness. And that's sort of one of the wonderful reasons to get vaccinated, is so that we can start having more normal social interactions with each other.
Great. Well, I want to thank you very much, Dr. Reimers, for taking the time this morning to better educate us and to answer our questions. We truly appreciate it. I certainly know how busy your schedule is, and this has just been wonderful. We're very grateful.
Thank you so much for having me, Stacy. And I know there's a lot of questions about how to get a vaccine, especially because all the criteria are opening up more. I would say talk to your own healthcare provider first, and then just be an active consumer, because there are vaccines out there, and there are even groups that are able to help you. There's something called San Diego Vaccine Angels. There's something called the Vaccine Finders. There's a lot of people trying to help everyone get vaccinated.
I also just want to take this opportunity to remind everyone that there will not be a forum next week. We'll regather in 2 weeks, and that will be the beginning of a creation care series.
Great. Thank you very much.
All right. Thank you all, and we'll see you in our Palm Sunday worship, which begins at 10:30. Take care.
Thank you.
Terrific.
Wonderful-
Thank you, Dr. Reimers.
Wonderful program.